有一个延伸荧幕的画面，中间那个是什么？好，谢谢。OK， 这样应该可以吧？Okay, so the first case is from a pleural effusion specimen, and the patient had a history of lung adenocarcinoma and received targeted therapy treatment. So in this specimen, on low power, we do see very scattered So we do see very scattered tight cluster of cell. On low power, we can appreciate this is the cell cluster composed of very big nucleus and hyperchromasia. So when we go to higher power, indeed this is a three-dimensional cluster of cells. So the cells show prominent nuclear atypia, which include increase the size of the nucleus, prominent nucleolus, which is almost as big as the adjacent lymphocyte, arranged in a three-dimensional glandular structure with vacuolated cytoplasm. So this is positive for adenocarcinoma, and this is consistent with the persistent or recurrence of the disease. So the tumor cell were not very plenty, but we do see very scattered, but very obvious positive cell cluster. So this is positive for adenocarcinoma. The next specimen is coming from ascites. The patient has a history of ovarian high-grade serous carcinoma. So in this specimen, again, you can see that we do have a lot of hyperchromated, crowded, like a three-dimensional cluster scattered in this body fluid specimen. And when we go to higher power, the morphological pattern is quite similar. The cell do have vesicular chromatin and prominent nucleolus arranged in very tight, like a three-dimensional cluster, along with vacuolated cytoplasm. So this is also consistent with the high-grade adenocarcinoma and compatible with the patient's past history of high-grade serous ovarian cancer. So the next specimen is relatively unusual. The patient is a 65-year-old male. He had a lung mass over left upper lobe. So it is quite uncommon for us to see the well-differentiated aspiration of a well-differentiated squamous cell carcinoma of the primary lung. And this is first is quite unusual procedure. I think the mass is very big and it has a liquefied like a center part. So the clinician aspirate the liquefied central part. So in this specimen, we can only see keratinized cells, but it is very difficult for us to identify the higher NC ratio hyperchromatic basal type of squamous cell, because this is all coming from the center of the tumor and with sort of central necrosis. However, just the presence of these highly differentiated, highly keratinized squamous cell in the lung is abnormal. So this is not our usual diagnostic scenario that we would want to see the high CO-like cells. For this specimen, it is impossible to find these type of cells given the location of the lesion was aspirated. However, given that it is in the lung, and it is impossible to have this type of like a keratinization of any benign lesion in the lung. So this is considered as squamous cell carcinoma. So we would call this specimen positive squamous cell carcinoma. So for these keratinized cells, most of them seems to be enucleated, suggests that it's either necrosis or it's like a something going wrong with the differentiation process. And when the cell has nucleus, still it does not show very striking atypia. But because this is most likely a well-differentiated squamous cell carcinoma, so we will still call this case as a squamous cell carcinoma. So this is a very uncommon type of specimen that we have. So the next specimen is a thyroid aspiration specimen. So before we received the specimen, I already got a call from the clinician because the patient had the past history of primary gallbladder adenocarcinoma. So they want to know if the thyroid nodule is a metastatic lesion or it is a primary thyroid tumor. This is very different regarding the following clinical management. So for this specimen on low power, first of all, we notice that in the background it's very clean. We do not see a lot of colloid. However, we do see a lot of cells, so the specimen is hypercellular. Most of the cells arranged in a very tight cluster. So then we need to go to higher power to take a look at the cell cluster. So if you go to higher power, you can appreciate that these cells do have some polymorphism, and the cells were not rounded, and we do see some like a small but distinct nucleolus here and there. So it does not very much look like a primary thyroid tumor. In this focus, the cells show a little bit oval shape, so it might like mimicking the morphology of papillary thyroid carcinoma. However, if you go around, you can definitely see some more higher grade of tumor cells. So usually for papillary thyroid carcinoma, we won't expect this degree of nuclear atypia. So overall, if you put the cells into the other specimen type, for example, in the EUS guided pancreatic biopsy, you will call these as adenocarcinoma. So this looks like more like a metastatic adenocarcinoma than the primary thyroid tumor. So just based on the morphology, we would call this positive, and this is compatible with metastatic adenocarcinoma. And just to making confirmation, we use the residual specimen to do a TTF1. So this is the residual specimen coming from the liquid cytology specimen, and we do a cytospin, and then we do TTF1. So you can see these typical cells were all negative for TTF1 in the nucleus. So this is confirmation for that this is metastatic adenocarcinoma instead of the primary thyroid tumor. And some of the focus you can appreciate the oval shape, even grooving. So just knowing that the clinical history is very important. The second thing is that for the PTC, usually we won't have this degree of nuclear atypia. So this is quite unusual. So we recently received more and more metastatic lesion from thyroid. That is kind of making our practice more difficult. But yeah, this is the reality now. So we need to think about the possibility of metastasis. So the final specimen is coming from a 72-year-old female with the pap smear. So she had abnormal pap smear a couple years, like 2 or 3 years ago, with high CO and status post lip cone. So this is, although she is very old, 72, because she had a history of high CO, so still it is under like a follow up with pap smear. So in this pap smear specimen, first of all, we know the patient is pretty old. It seems to be a little bit over maturation, but these cells can coming from the vagina, not coming from the cervix. And then we see that they were these like a mature superficial cell, but with enlarged nucleus, a little bit hyperchromasia. And these cells are actually quite abundant throughout the smearing direction. So here again, you can tell there is a cluster of more superficial cells with increased nuclear size and more hyperchromatic in the chromatin pattern, along with this coarsely granular pattern. So along the smearing direction, again you see a little bit hyperchromasia. So we do not see unequivocal like intermediate cells with high CO feature. Most of them were just these superficial cells, but indeed has enlarged nucleus and hyperchromasia. However, given the amount of the cells that we see, and also we do not see very good coelocytic change, I think this is still reasonable that we call this CIN2. Okay. So when we are making the judgment of the degree of CO lesion, we will need to consider, in addition to the cytomorphology, we will also need to consider the amount of the lesional cell that we observe. So for this case, here is more like coelocytic change. However, for the other focus, because the amount of lesional cells seems to be quite plenty, and the NC ratio is increased, but not as definite as the high CO cells that we usually observe. So it is reasonable that we call this CIN2. And because the patient has the past history of high CO, so it is possible that she developed a second lesion of the cervix. So we call this CIN2. Okay, thank you.